Hi everyone, I want to talk about hypercalcemia. And this will be part 1 of 4 of what we're going to talk about when it comes to high level of calcium, hypercalcemia. And the presentation today will be mainly on causes. Some call it etiology. Okay, let's go. We need to know the normal range of calcium before we can determine if it is high, low, or normal. It has a small range of 2.2 to 2.7 millimoles per liter or 4.3 to 5.3 milliequivalent per liter or 8.5 to 10.5 milligram per dl, depending on what you are using in your jurisdiction. The largest mineral in human body is calcium, and mostly in hydroxyapatite of the bones, in addition with phosphorus and hydroxide. Just a small amount of calcium is in the extracellular fluid. The one in hydroxyapatite is very, very large, almost 97 to 98%. The rest are found in the tissues. The presentation from parts 1 to 4 will be mainly on our concern about the raised ionized or free calcium level. That's what we're bothered about, because no one cares about the one in hydroxyapatite. And about 45% is bound to albumin in the serum. So you can see some bound to albumin, some in hydroxyapatite, and only a small percentage, very small, about 1 to 2%, is free or ionized, and that is the one that can give us problem. Just 2.2 to 2.7 millimoles per liter. Okay, hypercalcemia is a very common medical problem. It is more in the circulatory system, and less is excreted, less is deposited in the bone, then we're in trouble. Generally, there is increased gastrointestinal tract absorption, and that's why we have high level in the circulatory system. Or there's increased bone resorption. Bone resorption means there's osteoclastic activity releasing calcium from the bone into the circulatory system. Or we are dealing with increased vitamin D, and with increased vitamin D comes increased absorption of calcium, and that could also enhance bone resorption. We might be dealing with primary hyperparathyroidism. As a matter of fact, we cannot talk about calcium without parathyroid gland. So primary hyperparathyroidism will lead to increased bone resorption with tubular calcium reabsorption, giving us higher concentration in the circulatory system. Causes could be primary hyperparathyroidism, because we can't even talk about calcium homeostasis without reference to parathyroid gland. And the primary hyperparathyroidism could be inherited, as in men 1 or men 2. I could see some men smiling there that men are very important. No, I didn't mean the gender. Men means multiple endocrine neoplasia 1 or multiple endocrine neoplasia 2A. And it could also be inherited in form of familial isolated hyperparathyroidism. Also, it's possible to be inherited is hyperparathyroidism jaw tumor syndrome, which is a multiple ossifying jaw fibromas with familial primary hyperparathyroidism. Still on causes, we might be dealing with tertiary hyperparathyroidism. And listen to this. In chronic renal failure, phosphates will accumulate and there will be reduced level of active vitamin D. Hence, we'll be dealing with hypocalcemia. When there's hypocalcemia, then there'll be secondary hyperparathyroidism. We can also find secondary hyperparathyroidism in bariatric surgery, chronic pancreatitis, malabsorption syndrome, and so on. All is to increase the level of calcium. Remember I said, in the face of chronic renal failure, we'll have hypocalcemia, right? Then the parathyroid gland will become sensitized to act. So if secondary hyperparathyroidism is not corrected, then we'll be treated to an irreversible hypertrophy of the parathyroid gland in chronic kidney disease or end-stage renal disease. That is tertiary hyperparathyroidism. It may not be mediated by parathyroid gland. It might be familial hypocalciuric hypercalcemia. From the word familial, it means it's been inherited. Hypocalciuric means low level of calcium in urine. So, if the level of excretion is down, then what is happening? The level of absorption or reabsorption into the circulatory system is up. And it could be secondary to malignancy. I'll still talk about that later on. It might be secondary to parathyroid hormone-related peptide or increased calcitriol. Calcitriol is the active form of vitamin D that is produced in the kidney. We might be dealing with osteolytic bone metastasis or local cytokines, or we are battling with vitamin D intoxication. Thiazide diuretics could be one of the culprits giving us hypercalcemia. Still on possible causes of hypercalcemia outside parathyroid gland is lithium. High lithium, theophylline toxicity, excessive vitamin A, and teriparatide. Teriparatide is an anabolic agent, and it is a form of parathyroid hormone on its own. Some use it to correct osteoporosis, some use it for bone fracture healing. In the face of hyperthyroidism, we can have hypercalcemia. Might be dealing with acromegaly, Pheochromocytoma. I'll talk about that later on. Adrenal insufficiency, immobilization. As minute and insignificant it may appear, immobilization can tilt to hypercalcemia. That's why we'll encourage early mobilization in anyone having surgery or anyone admitted or anyone bedridden. Total parenteral nutrition can give hypercalcemia and, of course, make alkali syndrome. Still on causes, bone resorption, particularly in primary hyperparathyroidism. Here, hypercalcemia is due to parathyroid hormone-mediated osteoclastic activity, and that will lead to bone resorption. By that, we will have increased bone osteolytic activity going on, and the osteolytic activity will lead to more calcium being released from the bone into the circulatory system. We can also have intestinal calcium absorption increase and parathyroid adenoma in the face of primary hyperparathyroidism. Usually slight elevation in serum calcium less than 11 mg per dl or 2.75 millimole per liter, but it may be a severe hypercalcemia with over 12 mg per dl. In calcium stones, one should have series of serum calcium measurements if we're dealing with primary hyperparathyroidism. In secondary or tertiary hyperparathyroidism, we'll be dealing with chronic kidney disease. I've just explained a while ago, right? You can pause and rewind. Don't let me waste your time because we still have much to talk about. So in secondary and tertiary hyperparathyroidism, that is in another situation like chronic kidney disease. Low level of calcium or low normal calcium would trigger sensitization of parathyroid gland. But when it is prolonged, when it is not corrected, and the chronic kidney disease is still there, then we'll be battling with hypercalcemia, and that is tertiary hyperparathyroidism. The secondary is to correct the low calcium. Hypocalcemia will be found in the face of chronic kidney disease that will trigger secondary hyperparathyroidism. But if the cause of the hypocalcemia and secondary hyperparathyroidism is not corrected, will be treated to irreversible tertiary hyperparathyroidism, and in that case, we'll be battling with hypercalcemia. In malignancy, calcium could be as high as 3.25 millimoles per liter, and we're likely going to find that in cancer patients. Cancer patients, particularly multiple myeloma or metastasis to the bone, for example, in prostatic carcinoma, tissue necrotic factor, and interleukin-1, nephrotoxin, and interleukin-6 could be culprits here as well. Also, immobilization, like I've just mentioned a while ago, target disease, estrogen ingestion, theophylline toxicity, anti-estrogen like tamoxifen will have side effects as hypercalcemia. Hyperphosphatemia with binders. Hyperphosphatemia being treated with calcium carbonate as phosphate binder or calcium acetate to bind the dietary phosphate will give us hypercalcemia. Rhabdomyolysis, particularly rhabdomyolysis in the phase of acute kidney injury. During the diuretic phase of acute renal failure, some individuals will develop hypercalcemia. It's about 25 to 35% of them having rhabdomyolysis, the phase of acute kidney injury, during the diuretic phase of acute renal failure or acute kidney injury will have hypercalcemia. Congenital lactase deficiency would give us hypercalcemia, and of course, medullary nephron calcinosis. Metaphyseal Chondrodysplasia, hypercalcemia or hypophosphatemia will be found here, but they will have normal parathyroid gland. Pheochromocytoma. Though this is very rare, but it's possible, particularly in men 2, that is multiple endocrine neoplasia 2. It is due to parathyroid hormone-related protein. Adrenal insufficiency. Hypercalcemia is possible in Addisonian crisis. How about that? They will come down with bone resorption, increased proximal tubule calcium reabsorption, and of course, increased hemoconcentration. And with that, I've come to the end of possible causes of hypercalcemia. The next presentation will be on clinical features or symptoms of hypercalcemia. Thanks for listening. Remember to share and subscribe. I appreciate it. Thank you.